Okay, so hi everyone. Just for those who have joined, my name is Chloe. I'm the patient support assistant at Craig's Cause Pancreatic Cancer Society. Thank you for coming out to our support for caregivers. Today we're going to hear from Jessica Kasnick. She's a registered dietitian with Alberta Health Services. She has worked clinically for over 16 years in both inpatient and outpatient settings. Jessica works with oncology patients and is a lead researcher in pancreatic exocrine insufficiency. Her research will help translate evidence-based clinical findings into daily patient care. So we're super excited to have Jessica with us today. She's going to give us some great information that will hopefully be helpful. So Jessica, if you want, you can take it away.
Hi, everybody. Okay, I'm just going to start sharing my screen. And I think I see that everybody is muted, but just because sometimes we get funny feedback while I do my talk if people want to mute. And then I'll make sure we have a good amount of time at the end for any questions that didn't get addressed or come up as we go through my talk. I don't have to be out of here right away at, I guess for me, it'll be 11 o'clock, but everybody's spread out all over the place. So after the hour, I can stick around to continue with questions. And so no worries about that. You can place them in the chat while we go, and I can go back through them. Erin sent me a list of some questions that people had even submitted that they hope to get from the presentation. Some for sure were already embedded into my talk, and then anything I haven't addressed with my talk, I'll go through. So let's get going here. There we go. All right. So as Chloe said, I'm Jessica Kasnick, a registered dietitian in Alberta. I've been working in oncology for just coming up on 7 years now. And I see all patients at my cancer-specific hospital that have cancers of their digestive tract. That's kind of my area of specialty. But a huge portion of my role and kind of my interest and my passion or my research has all been with pancreatic cancer patients. And so this is definitely the area that I feel kind of most passionate about. So when we think about nutrition and pancreatic cancer, what can we do? We'll go through that today. Disclosures, I have none. So today we're going to go through and look at the nutrition implications of pancreatic cancer, identification and diagnosis of pancreatic exocrine insufficiency. I'm going to call it PEI for the talk instead of that long-winded thing, or pancreatic enzyme insufficiency. We'll go through treatment for PEI, being pancreatic enzyme replacement therapy, or PERT. Then we'll talk about, once we have somebody who's maybe not digesting well, digesting with their enzymes, what do we actually recommend that you eat and nourish yourself with? And then strategies to kind of combat common challenges that I see for patients with this disease and undergoing treatment. So when I started into the specialty of oncology, and specifically oncology in the digestive tract, how I approached it was thinking about the role each of those organs played in nutrition. Really understanding that, and then understanding if there was a tumor or cancer in that organ, what would be the impact to their nutrition or to their digestion. And so I really feel when I'm working with patients that you don't need a full physiology teaching, but it's very helpful to understand where your pancreas is and what it does, because when symptoms are occurring or things are going on, you're better equipped to understand. So a lot of the questions that I got sent are all different bits and pieces of challenges you're coming across because there is a tumor in your pancreas. So what does that mean? So we kind of start, in my mind, a little bit at the beginning with just a basis of, so we see this man here and we see an example of the digestive tract. Esophagus comes down into our stomach. Liver is kind of on the left hand or on the right hand side of our body. And then right behind our stomach is our pancreas. And the gallbladder funnels down into a tube in the head of our pancreas and connects with a tube in our pancreas and puts digestive juices into that kind of C-shaped section of our small intestine right after our stomach called our duodenum. And so as I go through the presentation and as we talk about what our pancreas does and how that affects our nutrition and malnutrition and things like that, I think it's helpful for us to kind of understand our pancreas is sitting kind of just below our rib cage, behind our stomach, and it connects right into my small intestine after my stomach and provides digestive enzymes and juices. And so we'll continue from here. So pancreatic function. Our pancreas has two main functions, exocrine function and endocrine. Exocrine function is production and secretion of digestive enzymes and juices. So there's three different enzymes that our pancreas produces. Protease, which helps us break down protein to be able to absorb it across the bowel into our body. Amylase, which helps us break down carbohydrates to absorb across the bowel barrier. And lipase, which helps us break down fats. Bile is another piece that works with lipase. Bile is made in our liver, stored in our gallbladder, and comes down into that same section of our small intestine, that C-shaped duodenum, to help us break our fat down. And so you may have noticed at times that you initially had issues with your gallbladder or issues like that with fat malabsorption or fat digestion, and that's all related to these different digestive enzymes and juices being impacted. So there's three enzymes my pancreas makes, and then it also secretes bicarbonate, which neutralizes stomach acid. So our food gets churned and broken down and then goes into that first section of my bowel, and it's very acidic. And the bicarbonate from my pancreas neutralizes that and allows my enzymes, or the enzymes I'm taking, to work and not get denatured to break my food down for absorption. Second main function of the pancreas is our endocrine system, and it's producing and secreting hormones for digestion. So the kind of one that I think everybody will probably have heard of is insulin. So our pancreas makes and secretes insulin, which helps us absorb the glucose out of our bloodstream and into our cells to use. It also secretes glucagon, gastrin, amylin, ghrelin, and leptin. And so some of those play a role in hunger and fullness or satiety cues, timing of digestion, and blood sugar control. Most of our pancreas is exocrine cells. Like the majority of our pancreas is made up of exocrine cells with just a small percentage of endocrine cells throughout the pancreas. So pancreatic cancer. The majority of pancreatic cancers are exocrine-based tumors. And so they're originating from those cells that produce our digestive enzymes and juices. 90% of those exocrine tumors being diagnosed are a type of pancreatic cancer called adenocarcinoma. So that's really the majority of the patients that I'm working with. A pancreatic adenocarcinoma originates in ductal tissue. So in that tube that runs through my pancreas to secrete my digestive enzymes, the tumors will originate from that ductal tissue. And so when I'm thinking about what the impact will be to my patient, I also want to consider the location of the tumor. So patients will sometimes be told the tumor is in the head of their pancreas. And we can imagine if all that ducts and tubing is going into my duodenum for digestion, if I've got a tumor in the head of my pancreas, that's going to impact how that's working. Ductal dilation, so the tube in my pancreas is expanded bigger than normal, and that only happens when it's blocked. So that's also a clue in terms of whether somebody might be struggling with their enzyme production or secretion. The overall state of the organ. So this is all information that as a clinician, I'm gleaning from your CT scan as I prepare to meet with you so that I understand what might be happening or what the risk is that you're going to be struggling with this component of your digestion. So another thing to consider when we're thinking about the function of your pancreas is a lot of pancreatic cancer patients may undergo surgery. So the most common surgery we see for pancreatic cancer is Whipple. And so this picture on the right is showing you an example. The left hand of the picture is a Whipple. So in a Whipple procedure, we take the head of your pancreas, we take that C-shaped part of your small intestine called your duodenum, we take your gallbladder, and then sometimes we take the base of the stomach. And then we reattach the liver, the tail of your pancreas, and your stomach to the next section of your small intestine. And so there's a pretty significant rerouting that happens. You still have all the bits and pieces to have very, very good kind of absorption and nutrition and digestion. But with a rewiring like that, there can be some challenges initially in your recovery, or perhaps that remaining part of your pancreas isn't quite making enough enzymes. And that's part of what we'll continue to talk about today. So then if we think about a patient who has a total pancreatectomy, their entire pancreas is removed, well, then I know they're no longer going to be producing any of those hormones that help blood sugar control, hunger, satiety, all those things. And they're certainly not going to be producing any of the digestive enzymes or juices and things like that. So we'll need to replace and provide that so that they're able to digest and function. A distal pancreatectomy is just the tail of pancreas. And then in some situations, a patient might undergo surgery where they're not able to remove the tumor, but the tumor is causing an obstruction in the area of that small bowel, or issues. And so they'll bypass. And so they'll attach the stomach to the next section of the digestive tract. And these are all the different bits and pieces of information that are good to know of what is the case for the patient I'm working with, or for you or your loved one, so that we know the best approach to make sure that we treat them and nourish them. So what is pancreatic exocrine insufficiency? We've kind of alluded to it or talked about it a little bit already, but it's a condition that's caused by reduced or inappropriate secretion or function of our pancreatic juices and digestive enzymes, causing maldigestion or malabsorption. So if I don't have enough lipase, protease, or amylase for the food that I'm consuming, those chains of nutrients don't break down far enough for my bowel to absorb them. They just go right through me. And so that's where we'll see pretty significant rates of malnutrition, or weight loss and issues with somebody struggling with pancreatic cancer. So PEI will be a deficit in all three of those enzymes, as well as bicarbonate. The prevalence that we see, 9 to 100% of locally advanced or metastatic pancreatic cancer patients are thought to have PEI. There's an increased risk if the tumor is localized in the head, if it's a larger tumor in general, if there's ductal obstruction or dilation like we talked about, or if it's with this history of chronic pancreatitis where there might be a bit of damage to your pancreas. So it's just not producing as much enzymes. Post-operatively, PEI, we're going to see it in about 80 to 90% of Whipple patients. 20 to 30% of distal pancreatectomy. It's really not as common in those patients. And then obviously 100% of our total pancreatectomy patients will have PEI. We know that PEI, whether somebody is in the beginning phases of their diagnosis and journey, gone through treatment, done treatment, even in the ending phase, perhaps where somebody has chose no longer for any treatment in their near end of life, pancreatic exocrine insufficiency will affect that quality of life because it's associated to so much pain and disruption for the patient. And so no matter where somebody is in their patient journey, they can really see a benefit from the treatment of this. We also see issues, obviously, with a patient's nutrition status if they have PEI. Post-operative survival and cancer-related outcomes are diminished if PEI is not addressed. Post-operative PEI can affect this. There's this assessment tool that clinicians working with cancer patients use. Well, we use it for sure across Canada. I'm not sure in the US, but we call it ECOG, and it is an overarching assessment of how a patient is doing, from how much they're up and about, how their weight is doing, how they're doing with treatment-related side effects. And we're always considering and assessing that every time we see a patient before we administer any more treatment, because it helps us understand if their body and if they are well enough for their treatment. So if somebody has a poor ECOG status, then we would delay treatment or dose reduce or not start treatment at all. And post-operatively, if PEI is present and it's not addressed, it has such a significant impact. We see ECOG affected and an inability to get them onto their treatment. So what are some of the symptoms? For my brain, I've broken them up a little bit. So I think of the symptoms in our abdomen. So diarrhea or steatorrhea. I wouldn't expect any of you guys to know or remember the word steatorrhea. Just note that it's a different style of diarrhea that we see when we have fat malabsorption. And so that diarrhea will look a little bit different in that it will have an oily residue on your toilet bowl or on the top of the water. Your stool will be pale and kind of fluffy and floating in nature. And so that's a little different than chemo-related diarrhea or infectious-related diarrhea, because that steatorrhea occurs when we are malabsorbing the nutrient of fat. So we see absolutely steatorrhea. We see just diarrhea, urgency with our bowel movements, bloating. So with the bloating, the real common pattern for PEI is you might wake up feeling not too bad that morning, but as soon as you start eating and going about your day, you start to develop bloating, and the bloating builds and builds and builds, and it's at its worst late afternoon, end of day. And that will be associated with gas, and gas that's quite foul smelling. And that's all just the moment I start eating and fully breaking down the nutrients I'm consuming, that malabsorption causes the gas and the bloating. We'll see reflux or heartburn, cramping, abdominal pain after eating, and gurgling. Gurgling is, so the gas and the bloating, the foul smelling gas, the gurgling are some of the absolute most common symptoms that I hear from patients related to PEI. Sometimes the diarrhea and the steatorrhea is being masked by other medications that kind of constipate you or slow your bowel down. And so you may not be having steatorrhea or diarrhea because you're on a pain medication that slows the bowel down. So those are some really common ones that I'm watching for. Endocrine-based ones will be low blood sugars, hypoglycemia, decreased insulin or diabetes medication. So not every patient, but a lot of patients with pancreatic cancer may already have had or have diabetes. And they may notice that all of a sudden they're not needing as many, as high of a dose or as much of their diabetes related medications. And that is related to the fact, it can be partly related to weight loss, but it is also related to the fact that you're not absorbing the glucose or the carbohydrate into your bloodstream. It's just going right through you. So as we correct PEI, you may notice changes again in your blood sugars. Nutrition, unexplained weight loss. So I know that this was one of the questions that I saw that was submitted. So if you or your loved one is eating what should be a good diet, sometimes we'll talk about it a little bit at the end. They need more now than they used to. But if they're eating a good diet and describing this sense of like, I'm so hungry, and sometimes I finish a meal and I feel like I didn't even eat, or hunger wakes me from my sleep at night. Those are common things that I hear from my patients. But yet they're still losing weight. That's a really good indication that they're malabsorbing what they're eating, that PEI is present, and that we need to treat that. Sarcopenia means the loss of muscle mass. So we all undergo sarcopenia with aging. It's a normal part of aging where we lose muscle, but there will be an escalated or an elevated rapid loss of lean body mass or muscle with cancer, and especially pancreatic cancer when we're malabsorbing. We can see weakness and fatigue, food avoidance. So another reason that sometimes I'm not seeing steatorrhea in a patient is because when I get to know you and I talk through how your eating is going, you stopped eating anything with fat, because when you ate anything with fat, you felt so crummy. Your symptoms were so bad. And so that again was a theme of some questions that came through to me is, what are the right foods for me? I have intolerances. I can't eat these foods anymore. The reality is, those are all symptoms of this PEI and malabsorption. And once we treat that, there is no need to avoid or restrict foods. So I think part of why working in oncology and working in cancers of the digestive tract, it so greatly impacts patients' nutrition. But with pancreatic cancer patients, and as we talk through the likelihood that somebody's going to have enzyme insufficiency and the impact it's going to have on your body, there's actually something we can do. So pancreatic enzyme replacement therapy, or PERT, is in PEI. So the pancreatic enzymes are these, see the little capsules I put on the slide? That's an example of capsules from one of the main brands. I certainly know one of the main brands listed here, Creon, is readily available in the US as well. I'm not sure as much about Codazyme ECS. It probably is. But for those patients in the US, I'm sure if you are on enzyme therapy, you're aware of Creon. So those are an example of the capsules. They are prescribed by a doctor or a pharmacist with prescribing rights, with or without the help of a specialized dietitian. The exact dosing is still not well established for pancreatic cancer patients, but we calculate it based on a couple factors that I'll talk about in the next slide a little bit more, but it is defined based on the improvement of your symptoms or your loved one's symptoms. So when we were on that slide with all those different symptoms listed, a patient does not need to have all of them. The reality is if they have pancreatic adenocarcinoma, I know that it's going to be affecting their exocrine function, and therefore I'm just looking for the presence of any one of those symptoms to indicate the enzymes. Really, some literature is asking us whether we even wait for symptoms and just put everybody on it. I think I'm mindful of that because a lot of patients feel quite overwhelmed by the amount of different medications you're on. So for me, the moment I meet a patient, I review your imaging and I review the background information of your medical status, and then we do an assessment together so I understand how digestion is going. And if there's even a hint of any PEI, we're treating it. But I make sure you and I agree on what your symptoms are. So is it the bloating that really resonates for you? Is it the gurgling? Is it pain? Is it the pale colored stools? We make sure that we're both aware of what's specific to you so that as we start your PERT, we can watch for the improvement and ultimately resolution of those symptoms. Pancreatic enzymes commonly used here in Canada are either Creon or Codazyme ECS. Those are the two main brands. Creon and Codazyme both come in varying strengths. So that number represents units of how much of enzyme is in each of those pills. So a Creon 10 gives you less enzymes than a 35. The ECS and Creon versions are enterically coated. And what that means is they have a coating on those little beads called the microspheres in those capsules that are protected from the stomach acid. And so when you take it, those enzymes don't just become denatured in your stomach. And that's a really important piece because there are some varieties of enzymes that are not coated for stomach acid. And I see a lot of error, at least for me in Canada, where the non-enterically coated version is prescribed to somebody with a stomach or taking it by mouth. And then they're not very effective because their stomach acid is denaturing it. So if you are taking them by mouth and you have a stomach, you need an enterically coated version. Each pancreatic enzyme capsule will have a combination of all three of those enzymes: lipase, protease, and amylase. So the dosing recommendations, like I said, are not well established for the cancer population. The main population that they're established for is cystic fibrosis. In that population, we use a calculation of your body weight in kilograms based on units of lipase in a range for a meal or for an overall maximum in a day. And so whenever I'm working with a patient, I always initially do that calculation. And what you come to realize is that will create a huge range of dose for those enzymes. And so where somebody fits into that dosing range is a little bit based on your symptoms and what you're eating. This isn't a good example of, like, if you are in a situation and you're not sure and you don't necessarily have a dietitian working closely with you, that tool that Chloe talked about that Craig's Cause has developed in terms of being an enzyme calculator to help you with your dosing would be really beneficial for you. So when we do the calculation, a rule of thumb is whatever you need for a snack or for a meal, you take half of that for a snack. There's no serious side effect or dangerous side effect to this medication. The main thing that occurs with this medication is an increase in stool production. So you can eat the exact same thing you used to eat, but you will now produce more stool than you used to. And so we need a game plan for making sure your bowels are moving well. So when I see a patient that's exceeding the upper limit in a day, the issue that I see that happens with that is constipation. And there's really not a lot of patients that should need above the upper limit. The only time I really kind of walk a line with that and struggle sometimes with a patient as we're figuring out dosing is when the entire pancreas has been removed. So if you still have part of your pancreas or all of your pancreas in situ, you don't often need the upper limit. So they're starting to do more research on how to dose it specifically for pancreatic cancer patients. And it's talking about something in the range of starting at 40 to 50,000 units of lipase per meal and 25,000 per snack. And you might think, well, what does that even mean? So Creon as an example, Creon is the pill that I have sitting on this slide. A common one prescribed is called Creon 25. And that 25 means there's 25,000 units of lipase in that pill. And so if I think somebody needs an initial dose of 50,000, they're going to take 2 Creon 25s for a meal and 1 for a snack. Whenever I'm starting somebody on pancreatic enzymes, I always calculate what I think the dosing will be for that patient and then have them start below that, start low and slow and gradually titrate up. I'm not going to go through this slide in detail, but in case this is shared with you or is of interest, I just wanted to give you a little snapshot so you can see realistically, Creon and Codazyme are almost identical. Creon 10s has almost the exact same units of enzyme as a Codazyme ECS8. Creon 25 and Codazyme ECS20 are comparable. At the bottom, you can see an example in Canada of a common non-enteric one that's prescribed called Codazyme. So there's no ECS beside it. If you are at home and you've been prescribed enzymes and you are taking them by mouth and you have not had your stomach removed, if you are on these plain Codazymes, they should be changed, just for you to know, because they're not going to be working very well for you because your stomach may be denaturing a lot of them. So that's a really important piece. I absolutely have patients that have had their stomach removed. And in that situation, or if I'm feeding a patient through a feeding tube and it goes past their stomach, then I'm using Codazyme that is not coated for any sort of stomach acid. Treatment. So PERT is needed with all solids and liquids that contain complex carbohydrates, fat, or protein. They should be taken right before your full dose, before the onset of your meal. And that's a really important piece. A common thing that I find patients have a misunderstanding about is that needing the enzymes is based on the texture of the food. So if something's really chewy or crunchy or difficult to digest, that they need more enzymes. But if it's a liquid, they don't need it. And that's not the case. This is about breaking the nutrient down to small enough molecules that can be absorbed across your bowel. Doesn't matter the texture. So liquids and solids that contain protein, fat, or complex carbohydrates need an enzyme. You don't need it with simple sugars. So things like an electrolyte drink, a glass of juice, pop, hard candy popsicle, those kinds of things do not need enzymes. If you're at a good place, you have a good dose that's working for you, you'll notice that a larger meal will require more. And that makes sense. If I'm eating more food, I need more enzyme to digest it. Or if I'm eating a food that is much higher in fat or protein than usual, I'll need to add an enzyme or two in that situation as well. I think the education piece around this is so important. I'll have patients come to me maybe through the surgical route. They've started with a surgery and then they're coming over to our cancer center for treatment afterwards. They've been prescribed the enzymes, but they don't really know why, how to take them, how they work. So I think a really solid understanding of why you need them, what role they're playing, how to watch for signs that I might need more in situations to adjust my dose. I think it's so important for you guys to have a solid understanding of this so that you can navigate it and manage those celebrations or family dinners where there's a different thing and you know what to do about that. So ensure that you guys have a plan for your bowels. It might sound kind of funny, but it's really important. As you start into enzyme therapy, you are going to produce more stool, and constipation or fecal loading or a buildup in your body will cause so much issue. And so we want to make sure that, you know, as you start enzymes, you will produce more stool. If you're constipated now, we'd better get that cleared as we start the enzymes. And then once you start enzyme therapy, you should be having at least 1 to 2 very large, soft brown stools. If that is not happening, you are not clearing enough stool. You may say to me, I never have gone to the bathroom twice a day. I was an every couple of days person, or that's not my normal. You are going to have a new normal now. So when we have the context of pancreatic cancer and enzyme insufficiency and treating it with PERT, your digestion will be different. So if you are taking enzymes, you need to stool every day and at least once or twice, and it's going to be larger than you think is based on what you've eaten. It should be unexpectedly large. And if it's not, something's going on and we need to deal with that. Evaluating your response to enzymes should be routine. So like I said a couple slides ago, it's really helpful if you understand which symptoms of PEI you are experiencing. And then as we get going on your enzymes, we're constantly reassessing has your bloating resolved? Is your gas foul at all? Is it back to a normal level of a human who just has gas here and there? Do you still gurgle? Is there pain? We're looking for whatever your symptoms are to completely resolve them. Side effects sometimes. If patients go kind of right out the door, start their enzymes on a higher dose, I see sometimes that patients will feel worse before they feel better. Symptoms being cramping, bloating, fullness, some nausea. And so that's why my approach has always been that you start really low and slow, and we titrate those enzymes or increase that dose of enzymes every couple of days till we find that amount that's working for you. Once we've identified PEI and somebody is on PERT, dietary fat restriction is not indicated. Even if you've had a Whipple and your gallbladder's removed, you do not need to restrict fat in your diet, and it is not recommended. So assessing and adjusting. So I have a patient, they have enzymes prescribed to them, but they're like just not working. They don't feel like they're working well. It is really not common that I have a pancreatic cancer patient who I think has PEI, but the enzymes don't actually work. It's usually something going on. The timing of how they're taking them, the dose, the frequency. There's usually something we can figure out together. So timing wise is a really common one that I see. So patients are sometimes spreading their dose out throughout the meal instead of taking the full dose right at the onset. I know that some of the medication information on like the sheet of Creon says to spread it out. I've worked with Creon and that company. They don't have good literature to tell us why. And if we understand the mechanism of how the capsule dissolves and how those little microspheres dissolve, you need the dose in you beforehand. So plate is sitting in front of me. I'm about to start my meal or my snack or my shake of any kind. I take my full dose and begin. The enzymes work for about an hour. So maybe we're spreading it out. If we're at an event, like I'm having some munchies and an appetizer, I'm waiting, then an entree is coming, I'm waiting. In those situations, I would encourage patients to just probably increase their dose and spread it out to not chance any sort of malabsorption. But timing is a really important piece for making sure that these enzymes work properly, or somebody took their enzymes, had dinner, and then, you know, after dinner, however much later they decide to have dessert. Well, you need to have enzymes again if it's been more than an hour since that previous dose. Frequency, that's another common one where there might be some confusion. Patients are taking it with their meals, but not their snacks, or they're taking it with solid foods, but not any liquids. And so I'm always trying to troubleshoot with the patient and make sure to kind of get to the bottom of it, because like I said, it's not common that if you have PEI, that these prescribed PERT don't work. So an example of that situation, however, is I have a patient who's been identified as having PEI. They've been on PERT. It's working well for months or an extended period of time. And then all of a sudden, they're not feeling well again. They're starting to have some of those symptoms again, maybe burping, some heartburn. And the spouse of the patient is like, it's like they just don't work anymore. So what is happening there is the bicarbonate is probably not working anymore, or you're not making enough of it. And so in that situation, if you're not on a PPI yet, which is called a proton pump inhibitor, which is a medication that reduces the production of acid from your stomach, then we will need to look to prescribe that. Because what happens is, if your pancreas is not neutralizing your stomach acid, that stomach acid in your intestine is denaturing the enzyme pills you're taking, or whatever enzymes you had left that you're making and secreting. And so that can evolve and happen throughout this journey or process for you. And so the common PPI medication that we use a lot here is called pantoprazole or pantoprazole. The more common name people might know is Pantaloc. And so that's one of the most common things that we'll layer in, and that often makes your enzymes work better, because then some of them aren't being denatured by that acidic environment. Another example of a situation, somebody has been identified as PEI, they're on PERT, it's working well in that all the digestive symptoms have improved, but they're still losing weight. So we do have to think about, is something going on with their blood sugars? Diabetes is really common in patients with pancreatic cancer. You may have it when you come to having your diagnosis of cancer, or it might develop through the onset of your treatment and your journey and stuff like that. So we need to consider, if PEI is not at place because we've treated it with PERT, then is something up with your blood sugars. And what I mean by that is high blood sugars will cause weight loss, because it means you're not absorbing stuff out of your bloodstream properly. And so monitoring for that is really important. Okay, diabetes and cancer. I'm not going to spend a lot of time on this, but I think it's an important piece for us to be mindful of when we think about pancreatic cancer, because it's the other main function of our pancreas. So diabetes is common in patients with pancreatic cancer. Very, in my mind, understandably, when the diagnosis of the cancer comes to be, sometimes our kind of other illnesses, whether it's high blood pressure, high cholesterol, diabetes, become less of a priority. So sometimes I'll hear lots of my patients say, oh, my doctor said, don't even worry about that anymore. Let's just focus on what's happening with your cancer. The reality is, though, the diabetes will impact your ability to treat and cope with your cancer. So having a high blood sugar is associated with more toxicity from your chemotherapy or your systemic therapies, which causes either a missed treatment, a dose reduction, a delay, or an inability to tolerate your treatment at all. Sorry, I just missed it. Hyperglycemia or high blood sugar. The tricky thing, I think, for you guys is a lot of the symptoms mirror that of stuff you might just associate to your disease or being on chemo. And so I've had that before, where I've had patients with very high blood sugars that they hadn't identified, because they're like, well, yeah, I feel tired. No, I don't have a great appetite. I'm losing weight. I have diarrhea or nausea. Yeah, I'm dehydrated. Well, I'm not eating well or drinking well. And they're kind of blaming all of the symptoms on the cancer treatment, when the reality is it's that their blood sugars are high. And when we correct that, they feel a lot better. So that is a really important piece for patients to be considered. So things to think about, whether you have diabetes or not. If your loved one has pancreatic cancer, or you have pancreatic cancer, watching for things like, you go to your check-in prior to your next chemotherapy, and they're like, oh, your blood work shows you're really dehydrated. You need to drink more. And you're like, I am so thirsty. I am drinking all the time. So your blood work tells us you're dehydrated, but you're actually drinking a good amount. That's a sign you are really thirsty. You're like, I don't know what it is, but I have just been craving orange juice lately. That's a sign a little bit. Nausea, your eyes feel fuzzy. So some patients are like, oh, it just feels like I need a new prescription. I just got to get to my eye. So blurry vision, needing to pee a lot. You get any little cuts and stuff seem to take forever to heal. Tingly feelings in your fingers and your toes, and unexplained weight loss, like we talked about in that other slide. And so you don't understand. I've had patients that are going along, they're on their enzymes, everything's going great, and then their weight just starts doing this. And we're like, what the heck is going on? it ended up that their sugars were elevated and we had to treat that. So we've figured out what's happening with your blood sugars. We've identified whether there's enzyme insufficiency and we've treated that. Now that things are improved in those situations, what should you actually do? What should you eat? So we definitely recommend a high protein diet. You need more protein than you used to, and that's related to trying to preserve your lean body mass as much as possible. Maintained and preserved muscle mass is associated to longer life, delayed tumor progression, and better prognosis, not to mention just kind of strength and quality of life. And so cancer is quick to try to break down muscle. So we put you on a high protein diet to protect you from that and to allow, in an ideal situation, gain back if there's been some losses. And so I would not expect a patient or their family to be calculating this. This would be something a dietitian or a clinician calculates to say based on your body weight. And then when you look at this, it's 1.2 to 2 grams per kilogram of your body weight per day of protein. Well, where you fit in that range is based on some factors we would assess you for. So have you had weight loss? How much weight loss? In what time period? There's like a bunch of different things we look at when we're deciding where to put you in that range. But an elevated amount of protein with a priority to you on what you're going to make up in your diet should be protein. You need more calories now than you used to, even if you feel you're really not moving around or as active as you used to be. Your body is just using more nutrition and needs more calories. We do not restrict fat. In fact, I use healthy fats often because they're so energy dense. You get 9 calories in a gram of fat versus only 4 in carbohydrates or protein. And so I get a lot of bang for buck when I'm using really good quality fats in patients' diets and in their nutrition. The other reason I really like using fats is that it does not elevate or affect your blood sugars at all. The big thing is just that if we are using fat, we need the enzymes to digest it. As I talked about in the previous slides, we absolutely recommend that a patient manages their diabetes. We look that they're doing that pre, during, and post any treatments that we're doing. And something I can't speak for all cancer facilities across the kind of US and Canada. In Canada, we really look for family doctors or your diabetes team to manage the diabetes. So if any issues are identified with your diabetes, it's not going to be your oncologist that treats that, but you're somewhat of a captive audience. We're drawing blood work regularly. We're giving you treatment regimes that can affect your blood sugar control, and the cancer itself can affect your blood sugars. And so we need to kind of collaborate, and you need to be aware of that association, but ultimately the management of your diabetes won't be done by your oncologist. We will suggest some vitamins and supplements. And so multivitamin, vitamin D, fish oil, iron, B12, those are some key ones that are safe to be taken during cancer treatments and are recommended. I'll go into that a little bit more here. So if a patient is malnourished, that's one of the questions. How do I know if I'm malnourished? So malnourished is when somebody has experienced weight loss or a deficit in their nutrition. It actually can occur quite quickly and quite easily. So I'm not sure I've met many pancreatic patients before we've gotten them on enzymes or gotten them established on good nutrition that aren't malnourished to a degree or quite significantly. But if you're malnourished, so if you have experienced weight loss, if you've experienced muscle loss and a change in your energy levels, strength and things like that, then a multivitamin would be a reasonable option, just a age-appropriate one a day. If your intake is poor, if you are understandably focused on your protein and fat, and so not eating a whole bunch of fruits and veggies, or you live somewhere where you don't have a great access to fruits and veggies, and can get those micronutrients from your food, then a multivitamin would be reasonable. Vitamin D3, it's a really important one, plays a key role in immune system for all of us. Evidence shows increase in apoptosis. Apoptosis is the death of damaged cells in our body. So in a cancer world, we want apoptosis. decreased ability of tumor to form blood vessels, preserved and even increased lean body mass. So lean body mass is muscle in my body, an improvement in sarcopenia or muscle loss. So that's huge from vitamin D. Vitamin D is a really nice one. It can be taken any time of the day. It doesn't need to be paired with anything per se. The pills are really tiny, so it's a great option that often a lot of my patients don't mind incorporating. Omega-3 fatty acids, there's some evidence that it supports an improved appetite in cancer patients specifically, and therefore improving their oral intake, improving their lean body mass or that muscle mass of the patient. Improved body mass, lean body mass and muscle is for everybody, not just a cancer patient with omega-3. Improvement of body weight specifically in advanced cancer, which is huge. That is a huge thing. With a lot of benefits. Promising evidence with improved tumor response when taken with treatments for cancer. Trend towards improved one-year survival in cancer population in one of the studies, the articles referenced down there. We have to walk a bit of a line here. So with fish oil or omega-3 fatty acids, make sure you are talking to your pharmacist or your oncologist so that they know you're taking it. High dosing of omega-3, so above 2 grams, could be associated with a thinning of the blood or an opening of the vessels that puts you at risk of bleeding. And sometimes there's other things going on in the cancer world that put us at risk of that. So always, before taking anything, make sure your team is aware of it. But these are some of the kind of main vitamins that there may be good correlation for a cancer patient to consider adding. Common barriers to good nutrition. So poor appetite or lack of appetite entirely, pain and indigestion when I'm eating and drinking, early or prolonged satiety, so feeling full really easily and staying full for hours, constipation or diarrhea, disruption in my bowels, and taste changes. These are kind of some of the absolute most common ones that I see when I'm working with patients. So what do we do? So you're going to be done with this word by the end of these slides. Multifactorial. So poor appetite is multifactorial. It's often a combination of factors. It could be disease related. Tumors and cancers in our body change some of the hormonal function of our hunger and fullness cues. So sometimes it's about the disease actually in my body. Sometimes it's about treatment related side effects. It could be from constipation or physical changes like I've had a surgery and wasn't eating for 10 days, eating well, or I haven't been eating well with the amount of pain I've been in, and so my stomach has shrunk. I just can't eat as much as I used to. And so really the most common cause that I see in my patients is constipation. So the first thing I'm always doing is what are your bowel, assessing them for what their bowels are doing. If there's any constipation, treating that. Because if you are full, you're full. You are not going to have an appetite. And constipation is so common in cancer patients, very understandably. We have a lot of medications that a patient needs to take, whether it's for pain management or nausea, and those will absolutely cause constipation. So are you constipated? Clear the constipation. How's your appetite? Manage any treatment-related side effects that are affecting your appetite. And really, what we can see is there's like a couple days in a treatment cycle where somebody's like, my appetite is just, I can't even look at food, smell food. I just can't. And a lot of time in that situation, I use a medication called metoclopramide. It's also called Metonia or Maxaran. A lot of patients are prescribed this as part of their chemotherapy medications, or even in radiation and post-operatively for nausea as needed. So it is a nausea medication, but it's also a prokinetic agent. And what that means is your digestive tract has contractions that move stuff through. And whether it's from surgery or illness or whatever, you can have a delay in the movement through your digestive tract. And so metoclopramide, when it's taken regularly during the day, can increase your appetite. it helps you digest your food more quickly. And it also treats that low-grade nausea of like, I can't even think about eating. I can't. So patients will often not have used it because they don't identify that like, oh, I don't even know what I feel like. I don't even want to look at it. They don't see that as nausea because they don't feel like they're about to be sick, but it's actually on the spectrum of nausea. It's just a low-grade nausea and it responds to the metoclopramide. Mechanical eating is another strategy that I'll use with patients. And so unfortunately, food for a time may become another component of medication for the patient. It's something that their body requires to be able to continue on. And so setting a schedule and eating on the clock versus when you feel hungry or ready. Sometimes for patients, if we wait for them to say, okay, I think I feel like this, that's not going to come. So mechanical eating can be helpful because we can't really trust their hunger and fullness cues. Small, frequent meals and snacks and things that are really nutrient dense so that they don't have to have a large volume. Focus on best times of day is another strategy. So sometimes patients feel their best in the morning. They have a bit more of an appetite. They're not as tired. They're feeling good. If there's a specific time of day where you or your loved one feels their best, do the largest meal of the day then. So maybe you always used to have a big family supper. Well, maybe it needs to be breakfast if that's when they're feeling their best. The other strategy that I use a lot and find very helpful is something I call 3 big sips. So at the end of every meal and snack, no matter how small it was, whatever size it was, the patient takes 3 sips. And so we talk about a liquid that they're going to use, whether it's just milk, a high protein milk, a protein shake, a smoothie that you've made, whatever it is, it just needs to have some nutrition and ideally protein. And then at the end of every meal and snack, you take 3 big swallows. And that does 2 really important things. One, by the end of the day, I hope that you've accomplished whatever that thing was, which gave you an increase in your overall nutrition and protein. But we did it really gradually and in a way that's not too overwhelming for the patient. And it's going to put just a little bit of pressure on your stomach. And it's almost, I'll talk to the patients about it, it's almost like physio for your stomach. We're going to gradually stretch your stomach back out, but we're going to do it with liquid so that the liquid doesn't stay in the stomach for long, so you don't feel that fullness and discomfort for long. And we're going to continue to work on that to 1, increase your nutrition, and 2, gradually allow your stomach to tolerate more volume. If you or your loved one thinks 3 is too much, do 1 sip. Start with whatever number is reasonable, but my common go-to is let's do 3 sips. Pain and indigestion, multifactorial, factorial as all things in our health are. PEI, most common for patients with pancreatic cancer. Usually if you're having pain or indigestion, it's from enzyme insufficiency. The other main cause I see is constipation. First things first, or really we're doing both. If you're constipated, clear the constipation. If you have enzyme insufficiency, treat it. And usually when we do those 2 things, pain and indigestion is resolved. Specific food restrictions are not indicated for patients with pancreatic cancer. They can have a full normal diet. It's the PEI that causes pain and indigestion, not a food intolerance. And that's a really big piece. I mean, if you've always had a food intolerance, absolutely. But I had a patient one time say all of a sudden, like, oh my gosh, like I've become gluten intolerant since I have pancreatic cancer. I think and the reality is it's just all to do with PEI. And we just have to treat that. Early and prolonged satiety. So feeling full really easily and for a long time. Again, multifactorial. Some of the most common culprits, constipation, PEI, and that's because as soon as we eat something that's not well digested, we get that sudden bloat or fullness feeling. My stomach has shrunk, or dysmotility. So my stomach is not moving stuff through as quickly as it used to. So first things first, with this symptom, clear constipation if it's present and maintain regular soft stools. Assess for PEI, treat with PERT, refeed the stomach using those strategies like eating on the clock, mechanical eating, 3 sips. And then another thing that can be very helpful is, again, this medication, metoclopramide, also known as Metonia or Maxaran. That prokinetic nature of the medication is so helpful for patients in so many different ways. So same with nausea. So I use it to treat nausea, fullness, poor appetite, dysmotility. That's one that I'm using quite often as a support as I'm refeeding. One thing to keep in mind, let's say for a period of time you would benefit from metoclopramide. It's not something that once you initiate, you're going to need to take for the rest of your days. It's not a medication like that. We can parachute in and use it for the 2 days each treatment cycle where you have absolutely no appetite. We could use it for a one-off dose for nausea. We could use it for 1 or 2 weeks after a really bad stretch of not eating and drinking well to kind of rehabilitate your digestive tract to be eating and digesting properly. So one thing to kind of keep in your back of your mind, this is not a medication that once you say you're going to try it, you've got to be on it indefinitely. Not at all. Constipation. So causes for constipation, multifactorial, but it's often things like intake, poor intake, dehydration, or medications. In your guys' population, medications are usually the top cause. Dehydration and poor intake might contribute, but if you are on a pain medication or a nausea medication we use often called Zofran or ondansetron, those are very constipating, and it doesn't matter how much fiber or fluid somebody's eating. If you're on those medications, you will have constipation. So you'll need a plan with your care team of stool softeners or laxatives to make sure that you're having daily soft stool. And this is another example where patients will be like, well, I never used to have a stool every day. What does it matter? If you are on a med that is constipating, you now need a bowel regime to allow you to pass soft stool each day. It's really important because if that doesn't happen, we see nausea, poor appetite, increased pain, all sorts of issues. Increasing your hydration can be helpful 100%. But again, if you have constipation from a pain medication, you cannot treat it with hydration. You will need hydration and that will help, but it will not treat it or prevent it. Diarrhea can be from multiple factors. PEI can cause it. Your chemotherapy or treatment can cause it, or we can see it from overflow or bypass. And so first, if it's PEI, we assess for that, we treat it, the malabsorption stops, and you no longer have diarrhea for malabsorption. If it's related to your chemotherapy regime, there's one chemotherapy regime that we use in Canada quite often called FOLFIRINOX. FOLFIRINOX has a component in it that is really known for diarrhea. So typically there'll be a very specific treatment intervention that we recommend to patients to treat their chemotherapy-related diarrhea. And you've got to make sure that you work with your team and follow that appropriately when it's treatment related. And then there's also this other one called overflow or bypass that I see. So if you are sitting at a place where you'd been constipated and you didn't all of a sudden clear all the stool out, but you went from constipation or not having a movement for a couple of days to just sudden watery diarrhea. No stool pieces in your diarrhea, it's just water. That in the sense that you just can't finish, that's actually that you are constipated, the hard stool is stuck, and only the liquid can pass by. And so we're going to treat that very differently, right? If somebody has treatment-related diarrhea from chemotherapy, we're often using loperamide or Imodium or a medication to slow that diarrhea down. If it's overflow or bypass, I don't want you taking Imodium if you're actually constipated, right? And so we're going to treat that differently. We're going to treat the constipation, and then the overflow diarrhea resolves by the treatment of the constipation. Taste changes. This is another one where I see, at least in my facility and in my world, it's not always caught well. So really the most common reason I see taste changes in my pancreatic cancer patients is because of thrush. So thrush is a condition that can cause loss of taste or a foul taste in your mouth. You'll have a sense of kind of things sticking or trouble swallowing, sore mouth, gums, or throat, increase in saliva, or this kind of slimy feeling in your mouth, cracks in the corner of your mouth, or coating on your tongue. Like a patient will be like, oh, well, yeah, I have coating, I just brush it off a couple times a day. A cottony feeling in your mouth, those are all actually signs of thrush. we all have the bacteria in our mouth that can cause thrush, but when we treat somebody with cancer, we reduce their immune system, which puts you at risk for thrush. So it's not something that you ate or drank that you shouldn't have, or some sort of weird infection. We all have that bacteria in our mouth. It's just that when your immune system dips down, you're at more risk. If your taste changes are from thrush, we just need to treat your thrush and things will taste fine again. Other reasons we can see treatment-related side effects, so mucositis. There's lots of resources and information on what to do about mucositis. Metallic, sweet, or salty, you can kind of have a specific taste change. All three of those respond well to acidity. So as long as you're not dealing with some really bad heartburn that's not well treated, using acidity like fresh lemon, lime, or citrus, or vinaigrettes on food. So I wouldn't normally have put fresh lemon on my roasted vegetables or onto things, but I now am doing it, and it really helps the taste changes. If metallic is the issue, cooking in glass or ceramic pans and dishes and using plastic or wood cutlery are all kind of strategies for the metallic. Using herbs and more intense sauces and flavors is another strategy, which again, you wouldn't typically have done. And usually when I start talking about this with the patients, they'll be like, oh yeah, I have really been enjoying orange juice lately, or oh, I can't get enough green apples, and they start to realize that that acidity or tart flavor, they've already started incorporating and liking. Speak with your team. There's so many resources online about managing taste changes, but really, I don't see a ton of it beyond that from thrush in pancreatic cancer patients, specifically in that regime. All right, questions. So Erin, do you want me to go through the list that was already sent that hasn't been addressed, or just address stuff that people are thinking right now? What do you think?
I think maybe we'll go through the ones that people have right now. I'm sure that they'll be re-asked. I think you did a good job of addressing a lot of them, and that was a fantastic presentation. So Chloe is going to go through the chat and read the questions, and then we'll see if there's any questions from the people who are here.
Sure.
Yeah, so thank you so much for that presentation. That was really informative and helpful. So we do have a few questions. So Karen's asking, how do you reduce the dose of Creon if it is a capsule format and enteric coated?
Reduce the dose?
Yes.
I guess so. What do you mean? Do you think there's a situation where you don't need the whole capsule? Is she on there? No. So I could give, not at all. So the lowest dose I would ever suggest to a patient, if I've prescribed 25 as the concentration, Creon 25, then the lowest dose I would have somebody take is 1. So let's say, I think what would help is if I gave an example. So let's say I have a patient who is about 132 pounds or 130 pounds. So if I were to calculate the range per meal for that patient, it's anywhere from just about 1 Creon 25 to 6. It's a huge range. And if I did the upper limit for that patient, it's 24 capsules. And so the reality is there's like a really big range. And so it's seldom that a patient with pancreatic cancer and PEI needs less than 1 capsule. And let's say you're having such a small amount, you're like, I don't know if I should take a whole capsule for this square of chocolate or this little piece of cheese I'm having. Generally, the upper limit dose is so high for that patient based on their body weight. And what we know is that really for pancreatic cancer patients, evidence is saying that this range that we use based on cystic fibrosis is too low. So we would have you err on the side of taking more. And so if you're having a really tiny snack and you've been prescribed 25s, I would just take 125. one of the 25 unit capsules. If somebody is really struggling with the size of the capsules, they can be opened up and the little beads can be put in applesauce. But again, I've never gotten into with a patient kind of divvying half of the capsule into applesauce to try to break it up. You really don't need to worry about the dosing that minutely. And the only risk, let's say you took a bit extra that day because you had all these small snacks and you feel like you took too much, there's no dangerous or serious consequence or side effect of these of Creon or pancreatic enzymes. It is just providing you with those 3 enzymes to allow you to break your food down. So if you got more into you, you might make a bit more stool that day, but there's not going to be any damage or risk to your body.
Thank you. So another question, for an individual who has gone through total pancreatectomy and gastrectomy, they can't use Creon. Over in my country, we only have Creon 10,000. So I think they're wondering if they can't use the Creon.
Oh, if their stomach, so it would be surprising if their country doesn't have a non-enterically coded version. So I would ask, are they on to say what country they're in? Okay, if it's not coming back. So I would be really surprised if there wasn't a non-enteric version, but if there isn't, then I would have to find it. You can put the beads in a solution to dissolve them. So when we need to use them to help with a feeding tube and stuff, we can make a bicarbonate solution. So using baking soda and water and dissolve that little coating on the microsphere to be able to administer the enzyme when I'm using it with a feeding tube. So you could probably do something like that to be able to dissolve that coating on the microsphere that stomach acid would have dissolved, to allow you to tolerate it by mouth. There's not, this topic is something we've talked a lot when we're dealing with enzymes in tube feeding patients, because those little beads don't go in a tube very well. So there's not going to be a clear recipe or instruction that I have seen in Canada. But I think first things first, I would make sure that your country does not have a non-enteric version. And you can always start, Creon, that company does not have a non-enteric, but Codazyme and other companies like BioCase do have non-enteric versions. And so looking into that first and foremost and taking that. If that is not available, then you should be able to work with your pharmacist or somebody to help you dissolve that little coating on the microsphere and take them.
Okay, that sounds like good advice. How much vitamin D should we take? And you mentioned taking vitamin D. Is there a certain...
Oh, yeah. Good question. And so we always say here in Canada that we need at least 2,000 international units a day because we live so north and don't have a ton of sun exposure. And now we don't want a lot of sun exposure for anybody, no matter where you live. So I would say a good number is between 2,000 and 4,000 international units a day. So sometimes patients take kind of 2,000 year round, but through the winter months when they're really not getting any time outside, or if they've had a huge weight loss or a sense of malnutrition that's quite severe, 4,000.
Okay, thank you. And my mom always craves non-alcoholic beer. Is that okay to take?
Oh, yeah. And she doesn't need an enzyme with it.
Perfect.
Yeah.
What about, we were told to follow a low fiber diet to prevent bowel obstruction due to mets in the peritoneum.
Oh, yeah.
Thoughts on this? It's very restrictive.
Yeah, it's needed. So unfortunately, it's needed. So what happens is your small intestines, and maybe they've explained that, but the small intestines are kind of, if we think back to that initial picture, you can get these little, we call them adhesions, but these little attachments throughout your abdomen with peritoneal disease. And it causes tight little narrowed sections in your intestine. So any skins or seeds like the skins on fruits and vegetables, little seeds and anything, any insoluble fibers. Even if I blenderize my blueberries in a blender till they seem completely pulverized, those little pieces of blueberry skin get hung up at those little adhesions and narrowed sections. And so, it is a balance of quality of life. In general, with my patients, admissions to hospital with bowel obstructions is so painful and derailing that they often are, you just have to weigh your quality of life and your pros and cons. But the reality is, with peritoneal carcinomatosis or peritoneal disease, you often do need to remove skins and seeds and insoluble fibers. So I usually have the patient fully remove those. And then sometimes we get the hang of it. Like for some patients, they can tolerate oatmeal. It doesn't need to be cream of wheat. We can find a bit of a tipping point because it is about how many little nooks and crannies your bowel or your mom's bowel has, and how narrow they actually are, and how restrictive you need to be. So there may be a bit of room for some flexibility for your mom, but sometimes the impact of your bowel obstructing is so detrimental, it may not be worth it. So I would work with like your dietitian to get a really good understanding of how you could try to liberalize. But in general, skins and seeds are always a no-go.
Okay, that's good to know. Here's another question. Are we able to get a virtual online consultation with Jessica? We are in East Africa, so we don't have a lot of medical help here regarding diet and how to manage.
I don't know. I don't think my license allows me to see patients internationally.
Okay. We'll definitely send
yeah.
them some resources. We have some resources we can send, so we'll definitely do that. We'll definitely.
Yeah, that's a bit of a heartbreaker, but I don't think I'm allowed to use my license internationally. I'm barely allowed to use it across provinces, to be honest.
Right. This is another question from international kind of perspective, but where do you go for PI assessment in Italy? They're trying to find a specialist there. I don't know if you know of specialists across.
Well, so what we would hope, and usually Europe is a bit ahead of us on this PEI, pancreatic enzyme insufficiency journey than we are. So people that are going to know about this is definitely, hopefully, oncologists that treat pancreatic cancer. But if they do not know about it, gastroenterologists will know about it. Sometimes it may be that you have to be your own advocate. So through Craig's Cause and their links, or through my talk and the references within my talk, you then go to your family doctor or you go to your oncologist and request to be put on enzymes. So I will say that in general, Italy as well as Europe is ahead of the enzyme game, Canada and the US. But if you don't feel that your team that is treating your cancer is aware of it, then you may need to grab some references online and bring it to them to advocate for it.
Okay. And is it possible to take Creon and the pantoprazole on the same time?
Yep.
Yeah. Okay.
Mm-hmm.
Is small intestine bacterial overgrowth a problem for many pancreatic cancer patients?
No, not at all. And so many of the symptoms of SIBO, or small intestinal bacterial overgrowth, I would really push to say that that's probably PEI that's not well managed, because with my patients, as long as I'm assessing really thoroughly for that and treating it, I mean, in 7 years, with almost all of my patients being panc, I've never had a SIBO.
Okay. That's good to know. Can my mom use enzymes if she never undergone any sort of treatment or surgery?
Oh, absolutely. So even in a situation where I have a patient who has declined treatment, or they unfortunately are not fit or well enough for treatment, they still should be assessed for enzymes. And if they want to be on enzymes, should be put on enzymes, because it doesn't matter where you are in your time of life related to pancreatic cancer, you will benefit. So even if it is just used to treat the pain that eating is causing, or the bowel gas or whatever the symptom is, even if you are near end of life, if you would like to eat and you have pancreatic cancer, you should be on the enzymes just to improve that piece of quality of life.
Okay, that's good to know. Is this session recorded? Yes. So if taking a PPI and sucralfate, does that inhibit the breakdown of the enteric coating of creon?
Oh, no. So sucralfate, I have a lot of patients using that for a real, like either an ulcer or an irritation in the lining of your esophagus or your stomach. And so it kind of creates a coating and helps that tissue heal. And then, like I said, the pantoprazole reduces the stomach acid. And so, no, neither of those factors would impact those enzymes. If anything, they would allow them to work better.
Okay. And is it true we have to take the creon only with plain water and not warm water?
Oh, I don't think you have to worry about it at all. I
Okay.
mean, maybe if you take it with piping hot, it dissolves a bit too quick, maybe, but I've never heard that or worried about that. I've never advised my patient on the temperature.
Okay. And what if there's constipation with DX of acute colitis post chemo?
Oh, so the D word you said,
It just says, I'm not quite sure what it is. It's just a D with an X.
It's diagnosis.
Oh, okay.
Yeah.
Oh, DX. Okay, you just said D. I was like, I don't know what that type of what that constipation is. Sorry. So even with chemo-induced constipation, so you don't get a lot of chemo-induced constipation, first of all. Usually the constipation that occurs in this population at the time of chemo is from the ondansetron or the Zofran that you're prescribed for the chemo infusion, just so you know. The actual like fulfirinox or gemcitabine, Abraxane, nab-paclitaxel, those agents don't typically actually cause constipation. So the only reason I'm pointing that out is more just you don't have to do something different for that constipation as any other type of constipation. So if somebody notices a pattern that with each cycle of chemotherapy, they get bunged up for a couple of days, they develop a bit of constipation, then I have them use a really gentle stool softener. Like if they know they're going to have chemo tomorrow, then I would have them take a dose of, in Canada and the US, we have one called Restorelax or Laxaday or Clearlax. It's a powder that dissolves clear in water that just softens stool. It doesn't stimulate the bowel. It's not a laxative, it's a softener. And so if I have a patient that just kind of gets slowed up or constipated with each treatment cycle, I just have them start a gentle stool softener right out the gates preemptively so that we don't spend 1 or 2 or 3 days at the beginning of every cycle building constipation and then trying to treat a buildup of 3 days and swinging into diarrhea. And so if you have this pattern associated to your chemo, then I would just be more proactive at preventing it from getting too bad. If somebody is on constipating medications, like pain medications, like I said, or needing the ondansetron or Zofran more often, then sometimes a stool softener isn't enough. But the bottom line is, if you have treatment-related constipation or constipation of any kind, you need to be using stool softeners or a combination of stool softeners and laxative, like an agent that actually helps push the stool out, because it will be so detrimental to be constipated.
Right. And is probiotic okay for cancer patients?
Yeah, so I think it's important for all of you to just make sure if your team has a pharmacist that's working with you or your oncologist is aware. The evidence around probiotic use on a continual basis it's such a new area of specialty that it is evolving and changing quite a bit. And so just for people to know, unless we don't actually recommend somebody just take probiotics every day all the time anymore. We know a bit more about it. So if you've had a major insult to your digestive tract, like C. difficile or an aggressive infection, if you've been hospitalized and had a surgery that's really affected your digestive tract and things like that, antibiotics, things like that. So if you have had an insult to your gut, and from that insult, you are having gas and bloating and diarrhea, then we could look to do a 1, maybe 3-month course of probiotics. But after that time, we would back off and allow your own native microbiome and bacteria to repopulate itself. And so we aren't anymore just the moment somebody gets antibiotics, putting them on a probiotic. We're actually waiting to see, did the antibiotics even cause diarrhea? And can you just resolve the diarrhea on your own? So we would recommend functional foods. So foods that contain probiotics help foster your own little microbiome to build itself up. Fermented foods, yogurts and things that have probiotics, but true pill-based probiotics, we don't recommend that you need to take all the time anymore. They're not, they don't have the same beneficial effect that we think. If you add a whole bunch of more bacteria in there, you don't just get a thicker lining or a more diverse microbiome. It doesn't work that way anymore. Well, we understand it better now.
Okay, that's good to know. And is it okay to give L-glutamine? Some ask to avoid it, others not, so it's confusing.
So with something like that, most cancer hospitals, whether you are meeting with the pharmacist or not, have access to a pharmacist. And what I would ask is that for me, I have the pharmacist input the specific supplement, like the glutamine brand and stuff that they want to take into this database that cross-references it with the different components of their treatment. And so what we learn is some of these supplements have an ingredient or a component in it that causes either the chemotherapy agents to potentially metabolize less in the liver and be less effective, or cause increased toxicities. And so things like glutamine or any kind of individual supplementation other than the vitamins that I listed, I would have your team just review. I work really hard that if a patient believes in something and wants to take it, as long as it's not going to increase toxicity or affect their chemotherapy, that I support that. But for that one, I would have them cross-reference it with your specific chemo regime and make sure it's okay.
Okay, that's good advice. And thank you, by the way, for answering these. This is great. Is Creon to be taken with meal or before meal?
So what I say to patients is when your meal or your snack or the thing is kind of right in front of you and you're about to begin, take your full dose of enzyme and start. If you get a couple bites in, fair enough, take it. But usually how I explain it to patients is I am ready to start. It's right there on the table with my plate. I take it and begin.
Okay. And what would be the cause of throwing up so much and how to deal with that?
So in pancreatic cancer patients, usually I would have to, it's somewhat like layers that I've got to go through and assess. So irretractable nausea vomiting is not expected. There are some chemo agents that just make people throw up lots. And for pancreatic cancer patients, you're not on one of those. So if that's happening, I got to get to the bottom of it. So to be honest, the first question I'm asking is if you're constipated, because constipation could be causing enough. First things first, I assess for constipation. Then I look for hydration. Really severe dehydration can cause really severe nausea. Then I look for constipation, hydration, enzymes. Are you not on them yet? Do you need to be on them? And then we do get to a place where we've got to consider that perhaps your chemotherapy is having a bit more toxicity. The other thing that can cause severe nausea is unmanaged diabetes, specifically hyper or high blood sugars. And so are you constipated? Are your blood sugars normal? Are you dehydrated? Treat any of those things first. use better antiemetics. So there are absolutely some patients that I have had that get very severe nausea from not so much the gemabraxane chemo regime, but the FOLFIRINOX chemo regime. And for that one, sometimes we need to give them a different combination of antiemetics, which is nausea medications. And so there's going to be a baseline nausea medication regime that all of you are prescribed with your chemotherapy, but sometimes we have to augment that. We have to change your dose. We have to use different medications. And so irretractable nausea vomiting as your norm when you're on treatment can't stay. So we just have to get to the bottom of why it's happening and treat it, but you should not be expected to just endure that as your normal for treatment.
Right. And will the high sugar in Ensure Calories Plus and Boost Calories Plus cause problems with Creon or hypoglycemias?
Won't cause problems with Creon. You just need to, because it has protein and fat and carbohydrate in an Ensure or one of those shakes, you need to take a Creon with it to be able to digest it. Some patients who have had surgery, right after surgery, a really sweet concentrated thing will make you feel sick. And so sometimes right post-operatively, Ensure and those really concentrated shakes make you feel worse. So I usually here in Canada use a low sugar version so that you don't feel as queasy from it. And so some of the ones we carry here is Premier Protein, which I definitely think is in the US as well. It's a high protein shake. It's pre-made, it's twist cap and drink, but it has 1 gram of sugar in the whole bottle. And so sometimes I use a sugar-free option. Sometimes I take those Ensures or things and dilute it with plain milk so that the sweetness comes down. So if you find a really sweet thing like those shakes makes you feel queasy, I'd make sure that you're dealing with whatever is triggering the queasiness, whether, like we've talked about, it's constipation or dehydration, or whether you need metoclopramide or a medication to take more in. But some strategies is to reduce the sweetness of things.
Any more questions that they want to ask? Everyone in the chat saying thank you, by the way, that this was a great presentation. And yeah. Oh, we have one more question. If have chronic pancreatitis and pancreatic cancer, should I be followed by a gastrointestinal doctor?
Well, like, I don't know if that's really my place to say. Here in Canada, it's not necessarily a standard. A lot of patients with chronic pancreatitis will have a gastroenterologist. Usually you just do because they've been managing the pancreatitis when it's had its flare-ups. Once you transition to pancreatic cancer with the chronic pancreatitis, it would be reasonable for the oncologist to manage the pancreatic care, unless you're admitted with a flare-up. Do you know what I mean? So it's not totally appropriate for me as a dietitian in Canada to say for sure if you should have both, but at least here in our pathway care, you've often started with a gastroenterologist at the first episode of pancreatitis, and then it's often that gastroenterologist that actually finds the cancer and then funnels you through to the oncology group.
Okay. And
I don't know if that answers the question, but
they said thank you, so I think it does. I just heard you say that you may not always be on enzymes if you had Whipple. How do you know when to stop them?
Yeah, I felt for time I just didn't have time to address that with you guys, but as a question right now, let's do it. So in general, it takes time for your kind of new anatomy to adjust and that tail of the pancreas to secrete and the enzymes to make it into your bowel appropriately. That can take time. It can take even as much as 6 months. So when I see my patients, they usually have their Whipple and then come for treatment, like chemotherapy after their Whipple. Usually during the chemotherapy period, we're doing so much to their body with chemotherapy that usually during your adjuvant or your post-operative chemotherapy, you usually still need the enzymes. But it's after treatment is done, I'll always talk through with them signs and symptoms of when you don't. And so it's not going to be a perfect science, but you have been going along, and what will happen is you'll take the same dose of enzymes you've been taking, but you actually get gassier. You get gassier, you have stinkier gas and bloating again that you didn't used to have. And usually what ends up happening with my patients, if we haven't pre-discussed it, is they'll come to me and be like, I started feeling worse from my enzymes. So the next time I ate, I didn't take them and I felt fine. So what I would suggest to a patient is, if you had been on them and it was established and you're not in active treatment and we don't think something is going on, like you need pantoprazole or Pantaloc, then if you are post-Whipple and you start to just actually feel worse and gassier when you take them, then just try a meal or snack without them. If you have no symptoms, then I would keep going without them. And then just ensure that you're not losing weight, that you don't start to develop symptoms. And then you can come off of them. So it's a reasonable percentage of my Whipples that post chemotherapy, they end up being able to come off of them and don't need them for their whole life.
Interesting. I think that's all the questions we have. So thank you so much for coming. This was amazing. And thanks everyone else.
No problem.
Too. Next month we'll have another support for caregivers if you're interested. Thank you so much, everyone.
Yeah, thank you, everyone. Thank you so much, Jessica.
Bye. Nice to meet everybody virtually.
Yes, thank you so much, Jessica, for the presentation. If anyone wants to stick around, I'm just going to do a quick tutorial on our PERT calculator. So if anyone wants to see that, feel free to stay tuned for a minute. So I'm just going to go ahead and share my screen. That's the wrong screen. There we go. Okay, so we recently launched a PERT calculator with Viatris, the Canadian, and we partnered with the Canadian Digestive Health Foundation. It's been Health Canada approved. So if anybody's interested in using this, it can just help to give a dosage of how many enzymes you should take. So this is the registration page. So you go here, register, and then it will send an email to your account. I recommend pinning that email so that it's at the top, so that whenever you want to use the calculator, you can just click that email to get to it. And then the actual PERT calculator here. So what you'll do is you'll put your weight in pounds or kilograms, enter that here, and then you can select your PERT treatment. So if you're taking, I know Creon's a really common one. So if you're doing Creon 25, you can select that. And then you can come down here and build your meal. So if, say, you're having chicken, you can choose how it's prepared. And then you can put in the number of portions that you're having. And you can go ahead and do that for all of the different food groups all through here. And then you can come down here. This is just more of a nice to know section in case you're interested. It just tells you the total lipase units that are needed to digest that specific food that you're having. And then you can come down here and it will tell you the total lipase units needed for the meal or snack you put in, and then the recommended number of capsules depending on your dose that you get, the recommended number of capsules for that specific meal. So you can do this for every meal and snack. It's pretty quick, and it will just give you a good sort of idea of how many to take, and can help sort of empower you to be able to take the number of enzymes that you need that will actually really help with your symptoms. So definitely would recommend checking that out. It's at digestthis.ca. I did put it in the chat earlier, but I will put it in again just for everyone to see if you want to click on it. There we go. Oops, and I spelled it wrong. Sorry. Whoops. There we go. There we go. Oh, and I'm so sorry. I did it wrong again. My goodness. Okay, let me try one more time here. Digest this.ca. There we go. That's the right one. So yeah, feel free to check that out. Otherwise, thank you everybody so much for taking the time to come to the presentation today. It was great having everyone. If anyone has any questions or anything that they would like us to ask to Jessica, please feel free to send me an email at erin@craigscause.ca or to Chloe at patientsupport@craigscause.ca. And we're happy to help with anything that we can. Thank you so much for coming, everyone, and have a great rest of your weekend. Bye.